welcome to GME Core Curriculum. Thanks for joining us a little after 7 o'clock this morning. Before we get started, one housekeeping item and one sort of global picture item. The housekeeping item, or really two. One, please put your name in the chat so we know you attended. And secondly, there'll be an evaluation link that'll be put into the chat later. Please fill it out. This is how we improve this process, and we've done a lot of things this year to improve this session. And the really purpose of the session is to really help give you some basic tools that you will then apply in your different programs, in your different workspaces. And actually talked to the program directors about that yesterday, that this is the beginning. This is what's going on. And, you know, it has to be built upon, and it should be built upon if we're going to take great care of patients and great care of our community. So for those who don't know me, I'm Arthur Ollendorf. I am the designated institutional official, the DIO for GME at Carilion. And it's my great pleasure to introduce both our speakers today, who I've worked with closely in different venues. To kick it off will be Sarah Parker, who is our Chair of Health Systems and Implementation Science, to be followed by Dr. John Burton, our Chair of Emergency Medicine. So with that, I will just throw it out to y'all. Dr. Parker, thank you.
Great. Yeah, good morning, everybody. Thank you so much for joining this morning. I know it's an early morning, so thank you very much. I'm grateful to be here today, and thanks to the OCPD team for setting all of this up. We can go to the next slide. So this morning, we are going to talk a little bit about what the kind of terminology around system safety is, and specifically, I'm going to show you what Carilion Clinic's patient safety and quality goals are. And then what I want to spend the majority of time on is not a theoretical part, but what can you do yourself to contribute to this kind of overall system safety perspective. So we're going to talk about near-miss reporting tools and exactly how that information is used, and what contributions you can make. All right, next slide. So typically when we think about patient safety, obviously everybody comes to work to take the best care of patients possible. It's definitional. It's at the heart of clinical work on a day-to-day basis. Will you hit again, Deb? However, we know just based on both based on the literature, but also based on personal experience, even the best of intentions can lead to drift, meaning kind of a movement away from perfection and toward how one actually gets work done. And so that can at times result in mistakes or in additional issues. The vast majority of the time when something goes wrong, it's an underlying system issue that is contributing to that problem occurring. Next. So the question then is, we can think and talk a lot about, well, I need to do better, or I need to be more vigilant, or whatever. But ultimately, the question that actually gets us to a safer overall system is, how do we design that system to be better, to promote and enable better patient care? Next slide. Thank you. So the difference between kind of an individual approach and a systems safety approach is a little bit like this old game of whack-a-mole. So an individual approach is, oh, I'm trying to fix this problem. This was you. I'm kind of hitting one thing at a time, versus let's change the system. So kind of the two sides of the coin are, any sort of mistake or issue or patient care issue that occurs is seen as a problem to be fixed, versus, like I talked about on the previous slide, drift can be seen as an opportunity. So these are data points. These are things that are important to learn from. In the traditional culture, which I do believe we are beginning to kind of move and shift, at least in the outward space or outward view, is just kind of try harder or do better. And the systems approach, which is kind of built into a lot of our quality and safety initiatives, is how do we think about, if we trust that an individual person is coming to work to take good care of patients, why would this particular action, which might seem unsafe to a naive eye, why would it have made sense to this person at the time? We can go to the next slide. And so this kind of perspective is what we call the systems perspective. So yes, patient risk factors are incredibly important in how, whether it's a procedure or a hospital stay or an outpatient visit go, patient risk factors are really important, as are the skills of the clinical team, those technical skills. But there's all this other stuff that influences how that care is actually given, how that care is engaged with by both the patient and the care team, and how effectively the goals of the care are actually achieved. So when we're thinking about drift or thinking about mistakes or issues, often they're related to these things that are in the central box, not necessarily to the technical skill. And typically, we kind of hone in on that technical side, as opposed to really thinking about what are these underlying issues that may have contributed to the problem. Next slide. So this is an example of, rather than taking that individual person-oriented perspective, to thinking about how do we design this system differently. So I'm sure you have heard about these adverse events where you've got an MRI machine that's on, and then the magnet sucks some sort of piece of equipment accidentally into the MRI machine. I think it's terrifying on multiple levels. The picture here, there was not a patient involved by any means, and this is not a picture of this happening at Carilion. This is just a general picture. But this is something that has occurred in healthcare institutions across the United States. And just on its surface, if you think about it, it's like, well, that should never happen. We should never have issues like this, because we have safety zones that are recognized. And yet, in order to give a patient proper clinical care, you may need a portable ventilator. So what we're going to walk through is thinking about different factors that might contribute to that error, and then looking at what are interventions, kind of weak to strong, that could prevent this from happening again. Okay, so when I'm talking about systems thinking, there are a few kind of different, I guess, anchoring points that are helpful, I think, if you walk into a situation and you need to think kind of more broadly than just the individual, exactly what went wrong. So in this is just an example, but in this particular case, if we think about the outcome of the ventilator in the MRI, which is all the way over to the right on the screen, there are a few different kind of contributing factors. So think about that central box that I said with system factors. Each one of these little kind of tilted lines, these diagonal lines, are elements that were listed within that box. And so this is called a fishbone diagram, because it allegedly looks like a fishbone. So you get the ventilator in the MRI, and then all of the different aspects of systems that may have contributed to this. I put this up because a fishbone is a tool that's quite easy to use. It's very intuitive. That is something that if you are looking or trying to understand or explore an event that might have occurred, this helps you think about the system contributions beyond that individual. So these labels here of environment, process, equipment, people, materials, these are kind of typical labels for the different bones of a fishbone diagram, and you can within those more deeply understand what are the factors that were present that may have contributed to that outcome itself. Can you click next? Yeah, so there's the ventilator in the OR, or in the MRI. Can you click one more? So ultimately, when you are looking at those different fishbones as system factors, you start to narrow down what are the major contributors in this particular instance. So a lot of those things could have been present. We can't boil the ocean. So what are the major contributors to that particular issue? And then you go about trying to create solutions that are sustainable and that are easy to maintain. So typically, we end up trying to go to kind of a training type mentality, because I won't I don't think training is easy by any means, but it is much easier to track, and it's much less expensive or resource intensive than some of these stronger interventions. So for example, in this particular case, we could train folks, hey, these are the lines, these are the safety zones, do not cross. Remember, don't cross. We're going to have a daily briefing in which we remind you, do not cross. All the way through to these really strong, that's what I would consider a weak intervention. It's completely human oriented, and it's not particularly sustainable. If we move to those strong interventions, this is something like, for example, attaching the a ventilator to a wall somehow, or providing some sort of zip tie and lock or a tether type system to hold that there. Again, it's not necessarily going to completely forever prevent this instance from happening again. However, it is a massive improvement over trying to train individuals to remember something. This is actually changing the system of care to do our best to prevent this particular issue from occurring again. We are saying it is possible that a ventilator will be needed in the MRI space. How do we ensure that it is as safe as possible if it has to be there? And so these more systems oriented things can help you there. So this is just another way to look at that example in kind of a non-specified way. So you can see weak to strong interventions. This is work that comes out of the VA. Dr. John Gosby did a lot of this work, where categorizing weak interventions versus strong. Weak is often defined as it's unsustainable or it's training oriented, it's very human centric. And then the strong interventions are actually a change in the system itself. So now to the second part of our learning objectives, which was how do we actually learn about what is happening in the system itself? And specifically here at Carilion, how do we learn about that? So as you all probably know, we have a near miss, or some people would say a near hit reporting system that is available for anyone to use at any point in time. It is available on Inside Carilion. You can quickly access it right there. And you can, I believe you are still able to report things anonymously. So SafeWatch is designed to gather some of these minor issues that might be contributing to those major systems issues. So for example, in our MRI example, if you had kind of noticed, oh, there's a ventilator that is constantly very close to the line, it could go over. Those kinds of things could be put into SafeWatch, or very real serious safety events can go in there as well. I'm emphasizing that because I don't want the filter to be, oh, this isn't a big enough deal for me to report it. More information is better. So if there are issues that you see, and you all are particularly important in this because you see a lot of the day-to-day work that goes on the floors in the outpatient setting, you all have a lot of insight. And so I think your particular perspective is very valuable when we're trying to understand what are those bits of the fishbone that aren't right. I think your perspective is important. If going online is just is not an option for you, or it's not something that you would like to do, you can always call this number, 981-7233, which is colloquially called 7SAFE. You can call that number internally and it will take you to a voicemail, and that voicemail is actually monitored, as is the online system, by 2 human beings who look and listen to every single event that comes through, and then sort and monitor and expedite and escalate the issues that are major, and then triage the other issues. Next. So I tried to kind of justify this previously, but I think it's very important that you all know why one should do this. Obviously, if you're involved in an error or near miss, you may have personally learned about how to avoid that particular issue in the future. It is, I guess I think, and I think we all would benefit if we view that as, it's not just my thing, it's part of building our community of learning together. So if you might learn something personally, but what about your coworkers? What about other shifts, other departments, other units at the hospital, and then ultimately other Carilion hospitals? Reporting these near misses helps us better understand the current status of the system so that we know where there are hot spots and so that those things can be addressed. In addition, your information gets fed in, like I said, to assist to a set of humans who actually look through this stuff, and they go out and triage and try to address a lot of these issues. It helps us plan, especially in our quality plan every year that we go through. So this data, it doesn't just go into like some black box and then you feel good about having typed something away. It actually is very important to understanding the current state of the system and how we can improve it. Next slide. So, like I said, it leads to our goals around being a patient safety organization, which is a federal designation. It also contributes to our current safety goals. We have something called a safety index, which is looked at by unit leaders as well as by the Clinical Advancement and Patient Safety team, or the CAPS team. It also is utilized at daily huddles. There's a noon huddle that occurs every single day with nursing and administrative leaders, as well as some physicians across the entire system. This information is shared there, particularly if there is something that has happened across multiple units or if there's a pattern of events. In addition, it helps us engage additional resources such as the trust team, which is a team of folks if something goes wrong and a caregiver, in addition to a patient, needs additional support. That is a resource that we have through EAP that is available to anyone who works at Carilion. It also helps with what Dr. Burton will talk about with error disclosure, and then we can get engaged with processes like a root cause analysis if something meets the hazard level that we need to engage with there. Next slide. So what can you do? If it's your opportunity, and you know, I do think that sometimes this can be construed as like this is a complaints hotline. I mean, I don't want to discourage people from reporting anything. I think this is really important. And I think the habit of providing feedback is really, really helpful. So you can tell us anything that does not go as smoothly as it should when you notice unsafe conditions. So even those little niggly things that you're like, oh boy, that's going to be bad someday, that we want to know about that. We don't want to know when it went. I mean, we do want to know when it goes bad, but we want to know before so that we can deal with it. Any sort of near misses, issues with equipment, obviously, please report any issues that are iatrogenic patient harm or iatrogenic issues. And then honestly, just things that give you heartburn. If you were worried about it, send it into 7SAFE. And if I had to say, I want you to do something specifically, if you call 7SAFE once a month, that would make a massive difference. Your engagement makes a tremendous difference here. Next slide. So I do also want to acknowledge, you know, when we're talking about patient safety, there's a lot of kind of internally driven reasons for patient safety. You are all here because you want to be excellent, excellent clinicians and take the best care of patients. There are also external metrics that we are measured by that are related to financial performance. So, you know, there is altruism, there is ethical engagement. There's also very real financial consequences for the work. Can you go to next slide? So this is our 2022 quality plan for CRMH, or for, excuse me, not for RMH, for the medical center at large. You will see here there are there are 6 different, there are 7, I apologize. There are 7 different metrics that we look at on a monthly basis. The reason why I tripped on that is I just got this data yesterday, so I apologize. So there are these different metrics. These are updated for this year quality plan. You can see not only do we have an individual that is engaged in leading and championing that effort, but we also gather this information on either a monthly or a bi-monthly basis. And that is used to evaluate current performance and to allocate resources. Next slide, please. And so, given these different metrics, if you can either put in the chat or write down for yourself, what would you need to do to understand these metrics better, or to understand how your work impacts these metrics? Deb, can we go back one slide just so that folks can see those metrics one more time? Thank you. Yeah, so what would you have to do to contribute to some of these different different opportunities? I think that second column, specifically the measures, tells you a little bit more about exactly what we're looking for. So I'll just give folks a second to look at that and then think for yourself, are there contributions that I can make?
You would like us to put them in the chat, Dr. Parker?
You are welcome to put them in the chat. I'm also happy for folks to keep it to themselves. I think it's up to you, but I think these are the main metrics this year for focus. All right, we can keep going. One more. I do want to acknowledge, specifically within the context of pandemic kind of shifting, as well as the higher rates of burnout among physicians compared to most normal Americans. The context of work today is pretty intense. Obviously, mental health is hugely important, particularly during COVID. Maybe you all didn't experience this as directly, but I do think a number of clinicians did. This idea of moral injury and moral distress, trying to figure out, how best to engage in clinical care when there is a lot of different dimensions for what patients would like done to them, what the best science is, and how that is, how evidence is evaluated and articulated. In addition, this life period, also kind of the world around us, can lead to exhaustion, and ultimately that creates this, from a human performance standpoint, which is my area of study, that creates additional risk. I would argue that these are all part of the system and have been empirically related to safety performance. So if you are exhausted, if mental health if your mental health is not as strong as it needs to be, all of these things do contribute to safety performance. They are one of the elements of that fishbone. And I would argue that one size fits all kind of solutions don't exist, but just know these are chronic challenges and you are not alone. I mentioned the trust team, but there are also other support systems available to you, particularly as residents, that you can get connected to through Dr. Ohlendorf or through others, should you need that. I just want to acknowledge that, thinking about the system can feel like, well, I'm just a small cog. What difference do I make? You make a lot of difference, and you matter quite a bit. So I just wanted to acknowledge that. So if we come back to our objectives, the first was to discuss a system safety approach, which we talked about, or I talked about, the evidence, and particularly focusing on stronger interventions versus weaker interventions. And then we talked about, for Carilion specific, and what you can do is reporting one event a month utilizing 7 Safe or Safe Watch. And then I do want to, again, to acknowledge that you are an important part of the system and you see flaws in a different way than other people do. Next slide. And if there are any questions, I'm happy to take those, or if you would like to throw them in the chat. I believe there's a couple of questions for you in the chat. And with that, I can monitor the chat so that I don't waste Dr. Burton's time.
Thanks, Dr. Parker. As we get Dr. Burton queued up, I think Dr. Parker said 2 really important things I just love to reiterate in this transition. Number one, I tell this to almost anyone I can talk to in hospital administration, on the medical school side, is that residents and fellows see things from such a unique ability. So your ability to see and make suggestions, and your ability to be the people who actually do the change, is massive. So when you see ideas like, hey, this could be better, it doesn't seem safe, please let us know, because I can tell you we don't see it as faculty, because you have a totally different lens and you guys are so boots on the ground. So I just encourage you, however you bring these up, just do it. because that's how we get better. So with that, Dr. Burton, if you're all queued up.
Okay, great. Thank you, Arthur. Appreciate it. Well, so I'm John Burton, the chair for the Department of Emergency Medicine here at Curlian Clinic. I've been a chair here for the last 12 years. And I'm not actually appearing in that capacity today. I'm wearing my other hat for the organization, which is that I'm the medical director of risk management and patient advocacy here at Curlian Clinic. So we'll talk a little bit about both of those things, patient advocacy and risk management this morning. Let's go to the next slide. Main thing we'll drill down on is disclosing adverse events and a little bit of the structure around adverse events, maybe address some of the questions that you might have percolating around in your mind around adverse events and disclosure of those items. Dr. Parker's pretty much already discussed our other two objectives, which is event reporting system and what exactly we'd like for you to report. She's done a great job on that, so I won't spend much time there. Let's go to the next slide. You know the history of error contemplation in the field of medicine, so I won't spend much time at all with that other than to recognize that we're all human, and as human beings, we not only commit errors and mistakes, but we also design systems that have those as well. And over the last 30 years, we've come to acknowledge that truthfully in the field of medicine, as opposed to sweeping it under the carpet on the other end of the spectrum, which a lot of when I trained in the 1980s as a resident, we swept a lot of things under the carpet, to be truthful about it. Let's go to the next slide. So a little bit of a lingo here, some typical terms: medical error, unanticipated outcome, adverse event. Another way to think about these terms would be similar to a malpractice claim. You know, in a malpractice claim, you have to have three things. Number one, you have to have a departure from the standard of care, and the standard of care is the standard as articulated by experts in the field. So it's not necessarily something you read in a journal or on an article or somebody says in a lecture, but there's some person who has expertise and then they render what the standard of care is. And then the argument is that you didn't match that standard of care or rise to that standard of care, which you could contemplate as effectively a medical error in a way. Secondly, then in a malpractice claim, you have to have some unanticipated outcome. You have, which in the malpractice world would be damages. You have to have sustained some damage from that error or that lack of adherence to the standard of care. And then finally, putting the two together, the third thing you have to have is those two things: the lack of adherence to the standard of care, and then those damages have to be related, or that is, they have to be causal to one another. There has to be a relationship between those two elements, which effectively is an adverse event. You've got a medical error and an unanticipated outcome, which translates to an adverse event. Just something to think about and to keep in mind in terms of claims in the future as you practice for the next 30 years in your career, as I have. You'll come across claims from time to time and threats of claims, and you always want to just keep that in perspective, the things that you have to have there in the structure. Let's go to the next slide. So let's talk a little bit about disclosures. Let's go to the next slide. We really, as I noted earlier, have shifted to an expectation in the whole world of medicine in the United States and worldwide that it is our responsibility as physicians, as nurses, physician assistants, nurse practitioners, healthcare providers to practice openly, honestly, tell the truth, and to render that truth when we observe things that are errors or mistakes in the systems. So we all carry that responsibility moving forward. And while that seems, well, that seems pretty simple, let's just tell the truth, it can get a little complicated because you have to get around to these disclosures. And usually disclosures are pretty easy, but sometimes they can be a little complicated. And so we want to talk through a little bit of those structures. Let's go to the next slide. So at Carillion Clinic, anytime that we've got an adverse event or a medical error, we want to tell the truth about that. And then if we've caused some harm through that error, hence an adverse event, then we want to speak to that as well. The good news is that usually when there is an error or some mistake, there is no harm associated with it. So we're very fortunate in that fact. But when there is, it further complicates and ups the ante, if you will, around the issues. Families and patients also are very concerned about not only their care, but also the systems around them and what items may have had the potential to cause harm, and how could these things happen in the course of their care, and how can we assure that those things don't happen again in the future. So at Carillion Clinic, we always want to speak to those things truthfully and to the degree that we can accurately anytime these things pop up. Now, the majority of disclosures, you as a resident physician or fellow and your attending physician, you will end up speaking directly to that patient or the family at the moment that it occurs. You'll say, here's the situation, and thank goodness we didn't have any adverse harm from this. Or maybe, there was some medical error around the choice of a medication. The patient had an allergy that was not acknowledged, and now they've had some adverse event where now they're having an allergic reaction. So maybe there is an adverse outcome as that allergic reaction. And so you tell them right up hand, hey, we think that the rash that you're seeing on your body is an allergic reaction. We didn't realize that you were allergic to penicillin. And so that's an error because it was right there in your medical record. Or perhaps we just discovered that today and we didn't know that you had any history of penicillin, and we've just discovered it today. So now the adverse outcome of that is that you've got this rash or you've got urticaria, and here's what we're going to do to affect that. Of course, there's two different scenarios where you knew about it or you should have known about it versus you discover it for the first time, this penicillin allergy, are two very different scenarios in terms of that discussion, aren't they? But then the outcome and how you close it are both pretty simple examples where you say, we're going to give you this medication, Benadryl, we're going to stop the other medication, we're going to put this on your chart to make sure this doesn't happen again. And that's how we're going to close this out. And here's what we would expect for you in your health care going forward. This rash is going to last for a day or two. We'll keep you on these medications, and there shouldn't be any other adverse issues. So it can be pretty straightforward like that. And in those scenarios that you encounter, hopefully not every day, but probably every week or certainly every month during your residency or fellowship, you don't always have to call in and pull risk management and patient advocacy into those discussions. If, however, the discussion is a little more, shall we say, spicy or complicated, that's when it would be a fantastic idea for you to call clinical risk management and patient advocacy. Now, the difference between risk management and advocacy is when we're facing the patient, it tends to be advocacy, right? When we're facing the organization, it's risk management. So it really is just the same coin, the two different sides of where it's facing and what the item is. Advocacy really tries to take the position of the patient and help them navigate at Carillion Clinic what needs to happen for them and what's in their best interests. And you might even say what we owe them in response to an error or mistake that has occurred. Risk management, on the other hand, helps to focus and streamline the organizational response. And where this hits you is if you've got to do that disclosure, or maybe on the other end of the spectrum, if you're worried you're going to get sued as a resident or a fellow or you're attending, then we help make your handling of that more efficient, accurate, and in your interests and the organizational interests as much as we can. So it's a little bit of a balancing act in making those things happen. So we're more than happy to help you at any time you have disclosures or events where they're a little complicated. Just give us a call and we'll work through it very quickly and decide how we need to proceed. Let's go to the next slide. You'll hear a lot about in the literature about disclosures and the history of disclosures from going from a very shut down, no error reporting system, so a very closed system, to then suddenly opening it up. And even to some extreme, the University of Michigan or Veterans Affairs actually even putting price tags on mistakes and errors and adverse outcomes and telling patients right up front, we made this mistake. This was an adverse outcome that you had, and this is the value that we place on that. In some cases, actual money. So we're going to give you this money in compensation for that error. So that would be really the extreme evaluation or structure of a proactive system of dealing with all errors and disclosures up front, as well as taking it all the way downrange as to what a liability claim would be. So that starts pulling in liability claims and the legal world into it, because you start anticipating things that might end up being lawsuits, which ultimately then tend to award money. Most patient errors and issues are not about money. They're more about patients being assured, how can this not happen again in their care, as well as in other individuals' care throughout the organization. So you want to always structure that. So you hear a lot about these systems that have opened up their systems to have a really wide range of options when they are doing these disclosures. And consistently, the message is that when you are operating in a truthful, open, honest environment as a healthcare system, you tend to do better financially and legally than if you were operating in a closed system. Another way of saying that, or the lesson from that and these studies, would be that the truth is going to be told eventually. It's just a question of how you're going to get to the truth. Let's go to the next slide. So that's really what it's all about in terms of the risk. I will tell you, though, it's a rapidly changing climate. Before I came to Carilion Clinic, I worked in New York. And then before that, I was in Maine for 11 years. Maine was a very low liability environment. New York was polar opposite, was a very high risk, high liability environment. Our patients were in New York were very suspicious as a group of what we were trying to do for them in their healthcare in the hospital. And it was a very confrontational setting. So you can imagine that then when you made errors or there were any issues in their care, they escalated very quickly with threats and pulling in attorneys. And I mean, this literally was, in that environment, it was such a high liability and caustic environment that it was nearly on a daily and certainly on a weekly basis that you were having those kinds of confrontations with patients, so much of which was just unnecessary, but they were just, as you would say in the South, spoiling for a fight. Virginia, where we practice here in Southwest Virginia, when I came here in 2010, was somewhat like Maine. It was a very low risk environment. And certainly not a caustic environment at all towards healthcare professionals. And in the 12 years that I've been here, that has changed a bit, and the pandemic has certainly worsened it. We've seen that on a national scale, that coming out of the pandemic, the availability of services and staffing, certainly in the healthcare industry, has really enhanced patients' levels of concern, if not even outright anger, at those services that are not immediately available to them, and challenges in their acquisition of services for their healthcare needs. So we've changed not necessarily because of the pandemic, but the pandemic has enhanced the acceleration of a change in our environment here locally to what I would classify now as probably a low to medium risk environment. It's still nowhere near Oregon or Mississippi or a lot of the Northeast states or Deep South states, but we've really got a somewhat moderate environment here. So you do have to kind of keep in mind where you're practicing and the local culture and history of the setting for your residency training, your fellowships, and then once you go out to practice, how that may change based on your new location. Let's go to the next slide. One way of thinking about this would be the Candor model. If you try to put it into a bit of a box or diagram it out, when you get to actually doing disclosures themselves and drilling down into it. Let's go to the next slide. If you think about it kind of like a SOAP note, subjective, objective assessment, plan, you're going to have this identification of an event. Then you're going to activate some system. And that may be, as a resident and fellow, you, and then activation of the system might just be you informing your attending physician, and then the two of you deciding what you're going to do about it. And then you're going to have this response and disclosure. Here, of course, in box 4 is investigation and analysis. And we tend to think, well, investigation and analysis would happen before the response and disclosure, but a lot of the facts that you would like to have, you may not have available. You may not know exactly why something happened, and you may not be able to really analyze it that well when you know it. So you're trying to balance, okay, so should we do a disclosure without knowing everything and having the investigation and analytics complete on this? Or should we go in immediately, or should we wait a while and let everything develop before we know the facts? And we've really teased everything out. And so, of course, a lot of that usually will depend upon the immediacy of the situation and the threat to the patient's health. So you'll always want to balance those things out and then ultimately coming to some resolution. A great example of that would be a couple of years ago at one of our hospitals, we had an error in the troponin machines that were calculating the level of troponin. So we had a small number of patients in a very small couple hours window of time that were subjected to that error in the lab. And they ended up having erroneous troponin results in patients in whom that was ordered in the hospital. Again, it was a very small number of patients quite a while back. And we discovered the problem within a couple of hours. There was a very adroit lab tech and then lab manager who saw something not happening with the machine that they thought should happen. And then they started looking at it a little bit closer, realized that there was a problem in the functioning of the reagent in the machine, and then shut everything down, called a halt to everything, and then started everything up again. So then we ended up going in, doing the investigation and analytics. So that's a great example where you say, gosh, you'd want to disclose that immediately. But since we really didn't understand what the implications were and the facts of it were till a couple of days later, and really even it took us another week or two to really ferret it all out, we had to figure out what's that balance with the disclosure to the patients, which then also included what were their adverse outcomes, what were the clinical resolutions that they were subjected to because of these errors in these level, which of course the troponin could either be adverse incorrectly high or incorrectly low, right? If it's incorrectly low, that's one set of issues. If it's incorrectly high, it could be the other. So that was another key part of teasing it out. Again, the majority of these, however, though, you're going to do them real time, probably 85% of the time, and you can handle them right there at the bedside quickly. And keep in mind that box 6, if it was on the slide here, would be if you're in the midst of contemplating box 3 and box 4, you might then want to pick up the phone and call patient advocacy and risk management so that we can help you as an external entity, not only in the disclosure, but also think through the timing of those events and even the characterization of them and how you really want to proceed facing the patient as well as to the organization in coming up with resolution. So let's go to the next slide. So what do our patients expect of us? They expect us to be truthful and to give them accurate information and support. Accurate information and support isn't always that simple because a lot of times it takes quite a while for the truth to come out. A great example here too would be autopsies. If we have an unexpected death in organizations that I've worked with, prior to probably the last 15 years where we weren't in an open disclosure and an open, truthful, honest, just culture in the organization, then you might just try to sweep things under the carpet and hasten things along so that things come to a closure. You have disclose as little as you can. Nowadays, we'll disclose everything that we know and structure it in a way that patients can understand. And if there's something that we don't know, but a step we could take, like an autopsy, we'll encourage the family to pursue that. If the family says, we want an autopsy because we want to know what happened, we'll say, yeah, we want an autopsy too, and we want to understand what happened. So there are cases in which we will pay for the autopsy as an organization because ultimately we know that the truth is going to come out. So we want to encourage a process of bringing the truth out, and an autopsy often will be that. Unfortunately, sometimes an autopsy results can be just as confusing as they are bringing the ultimate disclosure or truth to a matter. But you always want to give yourself the opportunity to let's just continue pursuing the truth, and that's the organizational structure. There are some regulatory requirements. So if we have a complaint against us or there is some adverse event that occurs, then there are external regulatory requirements primarily through CMS, the Centers for Medicare Services, that require us to not only investigate those things, but in some cases to report them back to CMS. And then finally, even a timeline that prescribes the timing that we have to proceed in that investigation and reporting it externally and internally. So that's another great example of where if you've got some big event that you need to disclose to a patient or a family, where when you pull in advocacy and risk management, we may tell you, hey, there is a regulatory reporting requirement on this. And so then you'll say, gosh, well, we're even more glad that we brought you in because we didn't know that there was a regulatory reporting requirement on it. All right, let's go to the next slide. A couple things about the bedside delivery of that information. Of course, sincerity, empathy, honesty. It's not a time to have your cell phone going off in the middle of the conversation or to be distracted. You want to try to speak on a level that patients understand. All those are pretty obvious, but you would be amazed at how often physicians in our rush and the demand that we have on our times and our organization places upon us, no matter where you work, that these very basic tenets of communication skills to patients and families can be overlooked or mismanaged. Let's go to the next slide. So a basic framework again is proceed logically, what happened, apologize, consequences, responsibility, close the discussion. Again, may seem very simple, but if you've got a very complicated disclosure or a high risk disclosure, a high risk one would be one where you know there was an error or a mistake made, and then there was a very significant adverse event, unanticipated outcome as a consequence of that. You might get pretty excited in the delivery of that information and get lost in the delivery of it. So a lot of times we'll actually rehearse with you, okay, who's going to say what, And what exactly are we going to say? How's that delivery going to go? Closing the discussion can be very complicated. You may have, I once did a disclosure where we had a family show up, and we thought, okay, we'll have 1 or 2 family members. And we had about 12 family members file into the room in this meeting that we had set up to do this disclosure. We had not anticipated having 12 family members. So then you can imagine, we're anticipating that this is going to be a 30-minute discussion. They're anticipating that all 12 family members, plus a couple on the phone in addition, are going to have the opportunities to shout at us for a while, as well as ask us any questions. And it could last hours. So closing the discussion, sometimes you'll even have to have a strategy for that, on where you absolutely need to end and how you're going to make that end. All the more reasons, if you anticipate it being complicated, give us a call and let us help you through that framework. Let's go to the next slide. Common questions that families will have is things like, who's going to pay? Is somebody going to get fired? Was there a student or resident involved? I was working a triage shift yesterday, and a patient and her husband came in, and while we were talking in triage, they asked the triage nurse if I was a resident physician, because they were suspicious of me sitting in there at triage, listening in and making some comments. And that was something they wanted to know right up front in their care. You deal with that on the front lines of your residency and your fellowship. So, those are common questions that people will have. But there is even elements around, should I have an attorney? And, what am I going to know about the outcomes of this? I want Nurse Smith or Dr. Jones fired, and I demand to know when they get fired and what the disciplinary elements are. And for so much of those things, there are personnel laws that also come into play for that as well, and the rights of those individuals in terms of disclosing to the patient what the ultimate outcomes are. So that gets a little complicated in some of those situations as well. Let's go to the next slide. And of course, you've got lots of barriers. I've pretty much touched on those a little bit. We'll talk about apology in a moment. Let's go to the next slide. So an apology, is that admissible? Is that a good thing to do? Is it okay to say that you apologize for things? In the Commonwealth of Virginia and most of the states and commonwealths throughout the United States, about 90%, there is an apology law that says that if you render an apology in the course of a disclosure or in the course of your discussion in the healthcare setting as a healthcare professional, that it's not admissible in court. Now, it gets a little challenging, so here's where you need to pay attention. What is admissible in court is if you start getting into the details of the event and pulling in causation around what it is you're apologizing for. So that gets a little bit complicated, doesn't it? So you can say, I'm sorry this occurred to you. On behalf of the organization, this is not what we would have expected for your outcomes, and I offer to you an apology on behalf of the organization for this event. And so that's not admissible. As soon as the patient then says, okay, Dr. Smith, what exactly are you apologizing for? When you say, well, what happened was when we were using the ink to mark your leg that needed to be operated on, we picked up the marker that was an invisible ink marker instead of the regular marker, and the invisible ink marker, we couldn't see it. And therefore we thought it was the other leg, and we cut off your other leg. And that's what happened. So then that is admissible because you're now getting into the details of the event and the actual causation of it. In general, when you're doing disclosure, don't worry about the legal admissibility elements. Tell the truth and be comfortable telling the truth. That's what we want you to do, and that's what your conscience should dictate to you. Carilion Clinic is a high conscience organization. You're going to figure that out really quickly. The people here have a very high conscience. It's part of our culture as an organization and probably in our region here. And we feel very uncomfortable when we're not giving a thorough disclosure. In the vast majority of settings, you should feel very good about that and not worry about admissibility. There are, however, situations in which you may contemplate just how far you want to go with that apology. Most often those settings are when there's uncertainty around things. So if you really don't know the facts or you're uncertain of the facts, you want to be cautious around rendering those causal details of what it is you're apologizing for when you've got that uncertainty. Let's go to the next slide. So we've talked about disclosure and adverse events. Let's go to the next slide. We pretty much wind up by mentioning SafeWatch again. Dr. Parker talked a lot about our systems of 7Safe and SafeWatch. And next slide. When you click on SafeWatch, of course, you'll go into the portal and be able to document those events. And we really expect and appreciate your doing that so that we can design systems as best as we can. Let's just freeze right there. And Arthur, we can end my slides right there because we've covered all the other details around event reporting. So thank you very much for your time. And we're very grateful of all of your work clinically during these very challenging times in healthcare. And thanks very much for allowing me to be presenting today to you.
Thank you, Dr. Burton, and thank you, Dr. Parker, as well. Thanks for sticking with us, everybody. I know we're running a little late. We also started a little bit late, and this is really critical information. So we will sort of defer any questions, but if you have questions, put them in the chat, and we will get any answers to the group or to the individual, depending on them. Or if you ever have any questions about any of this material, please reach out to myself for sure. I would assume the same is true with Dr. Parker and Dr. Burton. These are really important conversations. And once again, I hope we'll build on these in your individual programs because, I'm an obstetrician, we talk a lot about disclosure. It's kind of hard to disclose things about a newborn. It's different than disclosing something about, your 95-year-old father who, may have had a stroke. And that nuance is really important, and we have to teach that. So thank you so much. Thank you to our speakers. Thanks to our Office of Continuing and Professional Development for getting things organized, and have a great day. And thanks for taking great care of our patients.